A brain tumor can grow inside the skull for months, sometimes years, producing no headache, no vision change, no obvious neurological sign. By the time it announces itself with a symptom dramatic enough to send someone to a doctor, it has already been reshaping the brain around it in silence for longer than most people would believe possible. Most people assume a brain tumor would announce itself clearly and immediately. A sudden severe headache, a dramatic seizure, something impossible to ignore. And sometimes it does. But the medical reality that most people are never told is that the majority of brain tumors, particularly the kinds that become most aggressive and most consequential in adults over 50, grow for extended periods without producing any symptom that would prompt a person to seek medical attention. The symptoms they do produce are quiet, gradual, and almost universally dismissed as something else entirely. Fatigue, mild personality changes, word-finding difficulty, subtle shifts in balance or coordination. Things that are explained away as stress, aging, poor sleep, or distraction, while inside the skull, something continues to grow, to recruit blood vessels, to suppress the immune response that should be fighting it, and to take up space in a structure that has no room to give. Today, we are going to talk about why this silence happens, the specific biological mechanisms that allow brain tumors to grow undetected, because understanding them is the foundation of recognizing the warning signs that do exist. The brain tumor that goes undetected longest is not the one without symptoms. It is the one whose symptoms every person over 50 has been taught to dismiss as normal aging. Think about the past year. Maybe there were a few weeks where the right word refused to come during conversation. Not dramatically, just a half-second delay that felt slightly unusual. Maybe there was a period of unusual fatigue that did not match the workload. Maybe a headache that came and went, always with a vague quality that never felt quite worth a doctor's appointment. Maybe a family member mentioned that you seemed a little different, harder to read, slightly flatter in mood, and you both filed it away as a stressful season. These are the moments that most people over 50 live through without alarm. And for the vast majority of people, they are exactly what they appear to be: ordinary variations of a busy life in a changing body. But for a meaningful number of people, they are the earliest and most important signal that something is growing in a place where nothing should be growing. The difference between those two groups is often not the symptoms themselves. It is knowing what to listen for. Here is what we are going to cover today. The skull is a closed, rigid space with a fixed volume. Anything that grows inside it, any mass that occupies space that the brain needs, eventually displaces, compresses, or disrupts the tissue around it. But the brain has remarkable adaptive capacity, and tumors have evolved specific biological strategies that allow them to grow while suppressing, evading, and deceiving the systems that should detect and eliminate them. We are going to look at the most dangerous of those mechanisms: why brain tumors grow silently, what they are doing biologically during that silent period, and which early signals research has identified as the most important to recognize and report. By the end of this video, you will understand why brain tumors in adults over 50 are so frequently diagnosed later than they should be. Not because the symptoms were absent, but because the biology of tumor growth and the biology of the aging brain create a specific set of conditions that make early recognition genuinely difficult without the right information. That information is what today is about. Dangerous reason number 1. The brain's remarkable plasticity works against early detection. The first and most fundamental reason brain tumors grow silently is deeply ironic. It is one of the brain's most celebrated and most important properties turned against the person it belongs to. The brain's neuroplasticity, its capacity to reorganize, reroute, and compensate for damage or displacement by recruiting neighboring regions to take over disrupted functions, is what allows stroke survivors to regain speech, what allows the brain to adapt to injury, and what makes human learning and recovery possible throughout life. And it is precisely this capacity for compensation that allows a growing tumor to displace brain tissue for months without producing the dramatic, obvious symptoms that would prompt immediate medical attention. When a tumor begins growing in a region of the brain that governs a specific function, language processing in the left temporal lobe, fine motor control in the motor cortex, visual processing in the occipital regions, The brain does not simply stop performing that function the moment tumor tissue appears. Instead, it begins redistributing the work. Neighboring neurons take on additional processing load. Alternative neural pathways are recruited. Cortical maps reorganize around the intrusion. The function is maintained, imperfectly, at a slight cost in efficiency and processing speed, but maintained, while the tumor continues to grow. The person notices nothing, or notices only the subtle degradation that the compensation cannot fully cover. A slightly slower word retrieval, a marginally less reliable memory for recent events, a small reduction in processing speed that falls well within the range they would attribute to normal variation or a poor night of sleep. This compensatory plasticity is most pronounced in the slow-growing tumor types, the low-grade gliomas that can expand at a pace of several millimeters per year for years before transitioning to more aggressive behavior. Research tracking patients with incidentally discovered low-grade gliomas, found on brain scans done for other reasons, before any symptoms prompted evaluation, has shown that these tumors can be present and growing for an estimated 5 to 10 years before the compensation fails and a symptom emerges that is clear enough to bring the person to medical attention. 5 to 10 years of silent growth during which the tumor has been recruiting blood vessels, suppressing local immune activity, and displacing eloquent brain tissue, all while the brain worked overtime to hide the evidence. After 50, this compensation operates in a context of already reduced neural reserve. The aging brain has fewer redundant connections, reduced neuroplasticity compared to earlier decades, and less capacity to fully compensate for the displacement a growing tumor produces. What this means in practice is that a tumor of a given size will produce detectable symptoms sooner in a 65-year-old brain than it would in a 40-year-old brain, which is one of the reasons that tumors diagnosed in older adults are more frequently at a more advanced stage relative to symptom onset. The compensatory window is shorter, but the symptoms it produces when compensation finally fails are still subtle enough, still easy enough to attribute to aging, that significant time is still lost between the first detectable change and the moment someone connects it to a medical concern. Brain tumors identified before compensation fully fails, before mass effect, significant edema, or midline shift has developed, have dramatically better surgical and treatment options than those identified at advanced stages. Early recognition, even of subtle and easily dismissed symptoms, changes outcomes in the most direct and most meaningful way possible. Dangerous reason number 2, immune evasion. How tumors actively suppress the brain's defense system. The second reason brain tumors grow silently is not passive. It is active, strategic, and one of the most remarkable and most troubling aspects of tumor biology. Brain tumors, particularly the most aggressive types like glioblastoma multiforme, do not simply grow in spite of the immune system. They actively manipulate and suppress it, creating a local immunosuppressive environment that prevents the immune system from recognizing and eliminating the tumor the way it is designed to do with abnormal cells throughout the rest of the body. Under normal circumstances, the immune system operates a continuous surveillance program. Specialized immune cells patrol tissues throughout the body, evaluating cells for signs of abnormality, mutations, unusual protein expression, signals of cellular stress or malignant transformation. When an abnormal cell is detected, the immune system mounts a response, activating cytotoxic T cells that kill abnormal cells and generating immunological memory that prevents recurrence. This surveillance is imperfect, and tumors throughout the body develop various strategies to evade it. But the brain's tumor immune evasion mechanisms are particularly sophisticated and particularly effective, for reasons rooted in the brain's unique immunological status. The brain was historically considered an immune-privileged site, a region partially isolated from the peripheral immune system by the blood-brain barrier and by the unique immunological environment of the central nervous system. While the modern understanding of brain immunology is more nuanced than complete immune privilege, the brain's immunological environment remains distinct from the rest of the body in ways that tumor cells exploit. Brain tumors express molecules on their surfaces that actively inhibit T-cell activation, essentially posting molecular signals that read as normal do not attack. They produce immunosuppressive cytokines, particularly transforming growth factor beta and interleukin-10, that suppress the activity of immune cells in their vicinity, converting potentially tumor-fighting immune cells into regulatory cells that actively prevent an immune response. They recruit a specific type of immune cell, called tumor-associated macrophages, and repolarize them toward a pro-tumor, anti-inflammatory phenotype, so that cells that should be attacking the tumor instead support its growth by promoting blood vessel formation and suppressing immune activation. After 50, the immune system is already operating with reduced surveillance efficiency due to the age-related immunosenescence discussed in the diabetes video. The gradual decline in the number and function of naive T cells, the reduced responsiveness of immune cells to activation signals, and the shift toward a more chronically inflammatory but less effectively targeted immune state. An aging immune system that has reduced surveillance capacity encounters a tumor that is actively suppressing whatever surveillance remains. And the result is a tumor that can grow for an extended period without triggering the immune response that would produce the inflammatory symptoms, the fever, or the systemic signs that might bring a person to medical evaluation earlier. This immune evasion is also why inflammation-promoting lifestyle factors, particularly those that chronically activate the immune system without directing it effectively, may create conditions more favorable to tumor immune evasion. Chronic systemic inflammation does not enhance anti-tumor immunity. It suppresses it by exhausting immune cells, by elevating immunosuppressive regulatory signals, and by creating the kind of inflammatory microenvironment that some tumor types actively exploit for their own growth advantage. The relationship between chronic lifestyle-driven inflammation and brain tumor biology is an area of active research. And while direct causal relationships are still being established, the immunological logic is clear, and the epidemiological associations are increasingly consistent. Some people are wondering, if my immune system is supposed to catch abnormal cells, why does it miss brain tumors so consistently? The answer is that it is not simply missing them. It is being actively blocked from reaching them by molecular signals the tumor itself is producing. The tumor is not hiding from the immune system. It is disabling the immune system's ability to act. Dangerous reason number 3, location-dependent silence. Where a tumor grows determines what it hides. The third reason brain tumors grow silently is more anatomical than biological, but it is equally important to understand because the location of a tumor within the brain determines almost entirely which functions it will affect and how early those effects will be detectable. And some of the most dangerous locations for tumor growth are also the locations where growth produces the least obvious early symptoms. The brain is not a homogeneous structure. Different regions govern different functions with remarkable specificity. The primary motor cortex governs voluntary movement. Broca's and Wernicke's areas govern language production and comprehension. The occipital lobes process vision. The cerebellum coordinates balance and movement. The brainstem governs breathing, heart rate, and consciousness. When a tumor grows in or near these eloquent areas, regions with highly specific and immediately noticeable functions, even a small mass can produce early, obvious symptoms. A tumor near the motor strip causes weakness. A tumor in the language areas causes speech difficulty. These symptoms are dramatic, specific, and prompt rapid medical evaluation. They are the tumors most likely to be caught early. But the brain also contains large regions of what are called non-eloquent cortex, areas that do not govern immediately obvious, testable functions in the way that motor, language, or visual cortex do. The frontal lobes are the largest of these regions, and they govern functions that are real but profoundly difficult to quantify or notice in daily life. Personality, judgment, impulse control, motivation, social cognition, the ability to plan and sequence complex tasks, and the regulation of emotional responses. A tumor growing in the frontal lobe can reach considerable size before producing symptoms obvious enough to prompt concern, because the functions it disrupts are subtle, variable, and easily attributed to psychological or social causes. Frontal lobe tumors are among the most commonly late-diagnosed brain tumors in adults over 50, precisely because their early symptoms look like personality changes, depression, apathy, reduced motivation, or mild cognitive slowing that family members and physicians understandably attribute to stress, burnout, or the early stages of age-related cognitive decline. A person becomes slightly more irritable. Their sense of humor changes. They make decisions that seem slightly less considered than before. They lose interest in activities that previously engaged them. They repeat themselves more often in conversation. These changes happen gradually, over months, and are almost never connected to the possibility of an intracranial mass until the tumor has grown large enough to produce a more dramatic symptom, a seizure, a severe headache from elevated intracranial pressure, or a sudden change in consciousness. Tumors of the corpus callosum, the white matter bridge connecting the two hemispheres, are another example of location-dependent silence. This region governs the coordination of information between the two sides of the brain, and tumors growing here can reach significant size while producing only vague cognitive changes, mild personality shifts, and subtle difficulties with tasks requiring bilateral coordination, all of which are easily missed or misattributed in the context of an aging brain already experiencing some degree of age-related cognitive change. Before today, did you know that a brain tumor could grow for years in certain locations without producing a single obvious neurological symptom, while the brain compensated silently around it? Drop a yes or no in the comments. This anatomical reality changes how people understand the warning signs they should actually be watching for. Reason number 4, edema management and pressure compensation. The fourth reason brain tumors grow silently involves a specific physiological mechanism that allows the brain to accommodate a growing mass for an extended period before the pressure consequences become severe enough to produce dramatic symptoms. It involves the management of cerebral edema, the swelling of brain tissue around a tumor, and the body's compensatory responses to rising intracranial pressure. As a brain tumor grows, it disrupts the blood-brain barrier in its vicinity. The tumor's abnormal blood vessels are leaky and poorly regulated. They allow fluid to escape into the surrounding brain tissue, producing edema that can substantially expand the total volume of the tumor plus surrounding swelling. This edema is often responsible for a significant portion of the symptoms a tumor produces, more than the tumor itself, because it compresses and displaces functional brain tissue in a larger radius than the tumor occupies. Corticosteroids, medications like dexamethasone, dramatically reduce this edema by restoring some blood-brain barrier integrity, and the symptom improvement they produce can be so significant that the improvement is sometimes mistaken for tumor treatment response rather than simply edema reduction. The skull contains 3 components: brain tissue, blood, and cerebrospinal fluid, and maintains a delicate pressure balance between them. When a tumor begins adding volume to this closed space, the body attempts to compensate by reducing the volume of the other components. Cerebrospinal fluid is displaced from the skull into the spinal canal. Cerebral venous blood volume is reduced. These compensatory shifts can accommodate surprisingly significant increases in intracranial volume before pressure rises to a level that produces noticeable symptoms. Because the compensation happens gradually, and the brain adapts continuously to slow changes in ways it cannot adapt to rapid ones. This is why a tumor growing over months produces far less dramatic early symptoms than an acute hemorrhage of equivalent volume would. The slow pace allows continuous physiological adjustment that masks the accumulating pressure. After 50, the brain has somewhat more space within the skull than a younger brain, because age-related brain volume loss has created slightly more room. While this is not a benefit in any meaningful sense, it does mean that a growing tumor has a marginally larger compensatory buffer before intracranial pressure rises to symptomatic levels. The practical effect is that the pressure-related symptoms that would prompt most people to seek medical attention, severe headache, nausea, vision changes from papilledema, may arrive later in the clinical course in older adults than in younger ones with equivalent tumor volumes. Reason number 5, the mimicry of normal aging, why symptoms are dismissed. The fifth and perhaps most practically important reason that brain tumors grow silently after 50 is not primarily biological. It is cognitive and social. It is the fact that the early symptoms of brain tumor growth are, in many cases, clinically indistinguishable from the symptoms of normal aging, cognitive decline, depression, stress, and other common conditions of this life stage, and that both patients and physicians, operating in a context where aging-related explanations are statistically far more likely to be correct, consistently choose those explanations over the possibility of an intracranial mass. Memory changes. Mild difficulty forming new memories, slightly reduced recall speed, increased reliance on lists and reminders are experienced by the majority of adults over 50 as part of normal brain aging. They are also among the earliest cognitive symptoms of a tumor affecting the temporal lobes or hippocampal region. In the absence of other localizing symptoms, a physician evaluating a 58-year-old patient who reports mild memory changes is statistically far more likely to be correct in attributing them to age-related cognitive change than to a brain tumor. This statistical reality is appropriate, but it means that the rare patient with a tumor is consistently placed in the larger, more common category until the clinical picture evolves to the point where the rarer explanation becomes undeniable. Headache is the symptom most commonly associated with brain tumors in public perception. And yet, research consistently shows that headache as an isolated symptom is a poor predictor of brain tumor presence, because headache is extraordinarily common in the general population for a multitude of benign reasons. Brain tumor headaches do have specific characteristics. They are often worst in the morning because intracranial pressure is highest after hours of lying flat. They may wake a person from sleep. They worsen progressively over weeks rather than fluctuating as tension or migraine headaches do. And they may be accompanied by nausea or vomiting. But these characteristics are not always present, and headache alone, even severe headache, is far more likely to be a tension headache, a migraine, or a sinus headache than a sign of an intracranial mass. The symptoms that research has identified as most specifically warranting neurological evaluation in adults over 50, beyond headache alone, are those that are progressive rather than episodic, that represent a new and persistent change rather than a fluctuating one, and that combine neurological features with other systemic or cognitive changes. A new headache pattern that is consistently worse in the morning and associated with nausea. A first-ever seizure in an adult over 50, which is a brain tumor until proven otherwise and warrants urgent evaluation regardless of any alternative explanation. Progressive one-sided weakness or sensory change over weeks. Progressive speech or language difficulty in the absence of a clear stroke event. Personality or behavioral change that is noted by family members as a genuine and persistent departure from baseline, rather than a mood fluctuation. Gradual vision changes affecting one visual field consistently, rather than both eyes symmetrically. Any of these symptoms, particularly in combination, particularly when progressive over weeks to months, represent the clinical picture that warrants a brain MRI without delay. The brain MRI with gadolinium contrast is the definitive imaging tool for brain tumor detection, more sensitive and more specific than CT scanning for most tumor types, capable of detecting tumors of a few millimeters with high resolution, and capable of characterizing the tumor's relationship to surrounding structures with the detail needed for treatment planning. It requires no radiation, takes approximately 30 to 45 minutes, and is widely available. For adults over 50 with new progressive neurological symptoms that do not have a clear alternative explanation, it is the most important and most appropriate next step, and advocating for it specifically, rather than accepting reassurance without imaging in the setting of genuinely new progressive symptoms, is the most empowering thing a patient can do in that clinical conversation. Brain tumor outcomes are more strongly determined by the stage at which the tumor is identified than by almost any other single factor. And adults who advocate for imaging when they notice new, progressive neurological changes consistently achieve earlier diagnosis and broader treatment options. The most powerful tool against silent tumor growth is the informed, persistent patient who knows what to ask for. Before we close, I want to hear from you. Out of these 5 reasons, neuroplastic compensation, immune evasion, location-dependent silence, pressure compensation, and symptom mimicry, which one changed your understanding of brain tumors most significantly today? Drop it in the comments. And if someone you care about has been dismissing progressive neurological symptoms as stress or aging, a family member who seems subtly different, a partner whose headaches have a new quality, a friend who has been having word-finding difficulty that feels unusual, please share this video with them. The gap between a symptom appearing and a diagnosis being made is where lives are changed most dramatically. Closing that gap starts with information. Thank you for being here today. I will see you in the next one.